As Sarah mentioned, I'm a relative newbie to Regenstrief. I've been hanging out here and there the past few years. So I love to attend these WIPs. I'm usually one of the people sitting at home, and occasionally I have made the error of having my video on and somebody had to watch me eat my lunch. So many apologies, and thank you to Jennifer Carnahan who saw me that one time and warned me ahead of time. So I want to talk to you. The other caveat I have is, unlike Umberto's beautiful talk, the PR people did not get a hold of my slides. So these are traditional plain boring academics, so hopefully I can make it a little bit more exciting for you. So this is a project that's a little bit different because it is, number one, technically not research. I'll talk a little bit more about that here in a moment. It's really about impact. It's also a little bit different for me. As Sarah mentioned, I've got a couple of disclosures. I think technically most of them don't even need to be on here technically, but I think they do sort of influence my background and the way I see this current project, because I'm really most in my comfort zone in severe mental illness, mental health services, homelessness, substance use disorder. I'm perfectly comfortable there, and we start talking about chronic pain, and that is a brand new area for me. And so those are the sorts of projects that really influence what I'm thinking, and also some staff burnout work that I've done in the past really is a new lens when I'm thinking about implementation in the real world. So this is an ambitious outline. I confess that I have done a version of this in an hour-long presentation, so I'm going to try to whip through the first couple of points on the outline. And if we don't make it to the last two, I don't think that's such a bad thing when I have more data. This is a project that actually, the VA dropped the money in September and said you started in August. So we are brand spanking new on this particular project. So I just want to get some feedback on the beef of some of what we're doing right now. So a little bit of context that I think is important, because I know we're in a group that may not be as familiar with VA mental health services, is this is a project that is highly relevant to the Mission Act of 2018. This was an enormous, comprehensive piece of legislation to really help reform and overhaul the VA. It covers tons and tons of different aspects of VA services, but a big critical piece of it is about access to high quality service, increasing that at VA facilities, using telehealth if necessary to keep veterans in VA care. There's a palpable tension in the VA about proving that we're worthy of veterans coming in getting services directly from us rather than veterans choosing to go to non-VA community care. So that's something really heavy on the minds of the leaders in the VA right now. Let's see. So in terms of access and community care, just a couple of pieces of the Mission Act that I think are pretty important is the Mission Act took all of the various sort of disparate community care programs and folded them all onto one community care program. They added urgent care. That's brand new to the VA. So there's an urgent care benefit. And of course, I mentioned telehealth here. The bill actually mentions anywhere to anywhere, and it's a little bit of hand waving on what that actually means or how it's going to be executed, but that's something that's big on the minds of everyone. So a big deadline for us in the VA was June 2019. A lot of this had to be implemented by June, so the VA did their best. What's important to mention, and for those of you who haven't been around, is I think even those of us in our research center, we still continue to refer to the Roudebush VA Medical Center, and really the VA is pushing they've rebranded our local VA as Veterans Health Indiana. So to capture the fact that it's more than just this hospital that sits over across the parking lot, they're really trying to open up a lot more community programming across Indiana. So I've listed out a few of those. The big one on here is probably the Brownsburg contract. So the contract for construction has been signed. There's going to be about 16 pact teams that are currently in this building across the way that are probably going to get moved moved out into that area. So a much prettier slide, thanks to David Matthews, is sort of depicting where all those places are across Indiana. So some of these CBOCs have been around a long time, others are brand new. So, and some of them have been around to the extent like Terre Haute, where they're actually gonna build a new whole building. So they're even expanding some of those services. And even some of the bigger metropolitan areas, I don't know, I guess that doesn't come out. Like up north or where I'm from down around Lawrenceburg originally. And so those, it's not that there aren't community VA centers down there, it's just that the Lawrenceburg one is covered by the Cincinnati VA. So these are just the ones covered by the leadership at Veterans Health Indiana. So decentralizing a lot of care, you know, primary care in particular, off of the main campus is certainly an improvement. I also wanted to mention the VA Office of Connected Care because it plays such a large role in telehealth. I'm not going to spend a whole lot of time on that, just to mainly mention it. The VA has lots of different telehealth applications that Connected Care is in charge of. I've listed off a ton of these just for reference. So lots of fun, exciting things that are happening. Some of our staff are involved in a few of these projects we think is pretty exciting. In terms of synchronous telehealth interventions, I think there are mainly a couple of types. So clinical video telehealth is when someone is maybe, a veteran will come into the Wakeman Clinic that's down south of Greenwood towards Franklin. They might come in there and then a mental health specialist sits in the main campus and will provide care to them. So that person is literally in that CBOC clinic at Wakeman Center or Martinsville or wherever it is. VA Video Connect is a different kind of technology, and so that is where the veteran can be anywhere. The veteran can be at home, and the clinician who might sit anywhere can actually send them a link. They click on the link for the appointment and they can have the face-to-face video session right there. And then sort of a merge of these two, there's the Nurse Disease Management Protocol Program. So these are clinical nurse coordinators who are in charge of very specific disease conditions. So they will look at heart failure, COPD, diabetes, hypertension. I think there's even weight loss and smoking cessation. So they use a lot of remote monitoring and VBC style support. So I bolded that because we're going to come back to that. A couple other examples mentioned there. I want to skip through just to save some time. So the current project, Alan McGuire and I are co-PIs on this. It's a brand new RFA from VA's Health Services Research and Development Center. So the focus is on taking an evidence-based practice, preferably one that our center has had a role in improving the effectiveness, and then rolling that out so that veterans are actually impacted by this. So it's really, the mission isn't even implementation research. It is pure implementation. I put on here, just do it. Like they want to see that someone is actually doing an evidence-based practice that has not had a lot of uptake. So it's not a great amount of money, about $100,000 a year for up to 5 years. If we do well with the first 2 years, they'll give us years 3 through 5. So we really have to prove our worth in the first 2 years that we can actually get this model up and running and upright and get it out to veterans. So just, I know that Kurt Kroenke and Matt Baer and others have talked about chronic pain in the past, so I just want to state the obvious really quickly. Chronic pain is a huge issue here in the States. Some of the early Bob Kearns epidemiological work looked like 50% of VA primary care patients experience pain. The more recent data looks like it's closer to 65%, a huge, enormous societal costs. I looked it up, that 2019 GDP numbers, like the societal costs of pain are equivalent to the economy of Poland or Taiwan and just a hair shy of Saudi Arabia. So that's the non-economist view of it, just to get a scope of of what pain actually costs us. And of course, specialty pain care access for us in the VA, it's very limited what's available. And so then the demand on PCPs is really overwhelming. I mean, as some of our colleagues will say, well, it's my clinic day, I get to go deal with pain. I mean, that feels like that's their one thing that they deal with quite a bit. So the EBP that we selected, basically we took Kurt Kroenke and Matt Baer's work over the years and said, this is probably the closest that we have to an EBP that has not been implemented. So we looked across, I've listed them all off here, SCAMP, SCOPE, ESCAPE, Cameo, and CAMPS, which was Kurt's latest that I think you presented just a little while ago here. So we basically looked at the common elements across all of those studies. So all of these studies, there was some form of nurse care management, stepped care, collaborative care. They differed slightly in that sometimes it included pain and anxiety, for instance, in addition to pain, but they all, the common element was that they all we're really looking to do nurse care management, collaborative care for pain in primary care. So looking at the common elements. So I'm an implementation person. So the first thing that I like to do is I say, let's look at all of these studies and figure out what are the common elements. If all those studies showed an effect, what did it look like? So obviously telehealth in some form or another was common across all of them. It looked a little bit different in some places. Some of the studies, they preferred a little bit more face-to-face visits with the nurse care manager, and others were really focused on telehealth interventions. Self-management support for pain was common across all of them. That was almost universally provided by the nurse care manager. And as we've talked repeatedly to Kurt over several sessions, I'm looking at him right now, he says, you know, what these collaborative care models are is the nurse care manager does most of the work. Like that is the whole point of collaborative care, is really sort of unburdening the PCP. And I think that's sort of showing here. Pain symptom monitoring to inform care. So it's really a measurement-based care framework that we're gonna monitor pain symptoms over time. I think towards the end, there's sort of, the researchers have sort of settled on using the 3-item PEG as being really helpful in informing what sorts of care is provided. The PCP, there's coordination between the pain specialist, the nurse care manager, and the PCP, who is the main provider. Analgesic optimization, we'll talk a little bit more about this one. So I put pain specialist in quotes here because in most of these studies, it was Matt or Kurt as the pain specialist. And when we were talking with the chief medical officer for Visintin, our entire region in the VA, about pain specialists, he thought I meant a board certified pain doc. And he said, wait, you know, they cost 400 grand or more. I need these guys in doing procedures all the time. I'm not sure I can spare them. And we're like, oh, no, that's not what we're talking about. We're talking about if we could recreate a Kurt or a Matt, who is probably an internal medicine doc, primary care based, who's comfortable with some of the pain algorithms that we have set out and can really consult with the nurse care managers. That's who we have in mind. So that's been a tough one because that person that I just described doesn't really exist outside of these research studies. So that's a tough one, and I am open to any kind of feedback that you might have. And then the last part, team care planning, the nurse care management supervision. Typically, the nurse care manager who is doing a lot of the direct work in this is meeting with Kurt or Matt once a week. And so that's another common element that we're a little bit concerned about. So the problem is, and please, if you can let us know if you think this statement is incorrect, I'm actually happy to hear about that. I'm happy to be corrected because I would love, if someone is doing anything like this out in the real world, we would love to hear about and try to figure out what's working, what isn't. But we think that it's not really being implemented yet, certainly not in the VA. And keep in mind, we're not talking about an opioid tailoring intervention. That is not the point. This really is about managing chronic pain. And so there's, you know, a lot of opioid tailoring interventions that people are dabbling with out there, but not so much this collaborative care for pain. So the path of least resistance, I mean, maybe it says that I'm ultimately just a really lazy person, but I always look for the lowest hanging fruit when I'm thinking about taking a practice and putting it out in the real world. So I think, where will it fit the best right now, right off the bat? So I highlighted on one of those previous slides, those telehealth nurse care managers that use the disease management protocol. We think that we've got the right mix here. So those are nurses that are primarily assigned here in Roudebush, but they work remotely quite a bit, depending on which primary care team that they're assigned to. So I mentioned before that they have these very structured heart failure, hypertension, diabetes protocols, treatment protocols. Each nurse care manager is assigned to a pact team. There's one per they'll basically be at least on site with those pact teams once per week. They'd like for them to be a little bit more often, but I don't think that it happens more often than once a week. What they do with all these different conditions, once someone is enrolled, they'll send an actual box, in most cases, out to the person, so that if we need weights for heart failure or glucose monitoring, basically all that is in a box that's apparently very easy to hook up at home, and all of the vitals or different parameters come in and are displayed on a dashboard for these nurse care managers every morning. So, and it's most of the conditions, there is a vendor called Medtronic, and they're very user-friendly dashboards. Everybody really likes those. And the one for pain is called OneVision, and it's not exactly what we need to really match up with the model, but it's as close as we can seem to come. And basically, for most of the conditions, the criteria for payment, which is really important for these nurses, is they want the patient to actually log on to this box and input data or give a reading about 5 to 7 days a week. And then the patient can also click on a box or give a phone call to the nurse to say, I really would like to talk to you. And then they can pick up the phone and call them or do a telehealth visit if needed. And they also provide a lot of self-management support. Care coordination is certainly there. I've spent a couple of days with one of the nurses, and she's really comfortable just picking up the phone and trying to call a doc about a particular condition or a med or a need that needs to be filled. So, and I guess the other thing I want to mention is these are not nurses straight out of nursing school. These are the most experienced nurses. They feel very comfortable with like the diabetes protocols. Unfortunately, they did, up to one point, they could actually do some titration on diabetes meds and other medications, and I guess there was some catastrophe somewhere in the VA, and that privilege was pulled from these nurses, and they're kind of disappointed about it because they felt like very confident in being able to do those things. So a little bit of a setback in their scope of practice, I'd say. So we think this is the way to go, at least initially. So if I think about that table of all the common elements of Kurt and Matt's protocols, they really check off a lot of the boxes. Certainly telehealth, we've got at least some overlap there, that we've got some ability to really function on an interdisciplinary team that's connected to the primary care provider. There's a function for symptom monitoring. It doesn't look exactly like we want it to look, but it's there. The analgesic optimization, I mean, we are undoubtedly hitting some roadblocks here on how to really make that happen. And I'll talk about that here on the next slide. And then care coordination is a slam dunk for these guys, I think. They're really able to do that well. One thing that we're thinking about, and I would love feedback on, we've gone back and forth on which patients to target. So in the first year, we just have to do it with some people and maybe just a dozen veterans. So it's not as big of a question in year one, but certainly in year 2 and beyond, thinking about which patients to target. These particular programs right now, thinking of all the other conditions that they're mainly serving, they're getting most of their referrals from inpatient and ER. I think that their chronic pain patients are probably going to come from their primary care providers, but I'm not completely sure yet. So what we're envisioning right now is that these might be patients who need some kind of extra help with pain beyond what the PCP feels like they're able to give. Maybe there'll be veterans who are not so interested in specialty pain care. And I mean, whether it's true or not, I think there's a lot of veterans think if they're being referred to the specialty pain clinic, they're just going to take me off my meds, and there's some resistance to going there. But certainly we want the PCP to be on board and to be open to sort of communicating with the nurse care manager. And then because these models were stepped care models, we were thinking that we would hold off on referrals to the pain clinic until after we get a non-response with the actual direct services. And so we'll find out if that's actually too limiting or not. Right now, the nurses, they're used to just, if they feel like somebody needs some alternative care, they just refer out for that and they keep seeing them. So that might be a little bit too limiting. It sounded nice in the grant proposal, you know, it's appealing, but I think in the real world, it might be hard to get people to hold off on those referrals. So our impact goal that we're looking for is really just local implementation. And then in years 3 through 5, we might branch out beyond the local VA to other regional hospitals to see if they're interested. We've got a little bit of interest from the leadership at the VISN level. And certainly we want to sort of identify what implementation strategy bundle, what that bundle is going to consist of. So certainly some basic training. These nurses don't have a lot of time, so they don't want to give up the time necessarily that Kurt would ideally say is needed for the nurse care managers. So what can we get away with is sort of one question. Like, can we have a couple of 2-hour trainings to kick off and then try to incorporate other information in some weekly meetings if possible? And so really coming up with a toolkit and some helpful resources for implementation as part of our goal. So our year 1 scope is really just to adapt the common elements, figure out how to implement those locally, and then try to branch out to a few more clinics in year 2, and then move on outside of the facility in year 3. So I know this is tiny writing, I apologize, but it was just easier to have it all in one big spot. So obviously, what I mentioned before, the pain specialist not really being someone that is common in the real world. Right now, we're going to get by. Matt volunteered to meet with our nurse care managers who are part of the pilot once a month. And so we're hoping that we can sort of figure out if that's what's needed and maybe think of some alternative models. If we were going to go to Saginaw, Michigan and trying to implement this model, who would fulfill that role of the pain specialist, I think is going to be a critical piece. So certainly the ongoing pain monitoring with the disease management protocol, that box that goes on the veteran's home, it doesn't use the actual pain measure that's been used in the research protocols. We're going to have to figure out how to get by with that. We think that those protocols are reviewed every couple of years, so there might be a window where we can sort of work with that vendor to say, hey, we think you could make some changes that are closer to what they need to be. The other issue with monitoring is that it might make sense for monitoring a patient with heart failure you need the weights every day, you need to watch for weight gain, but for chronic pain, we're not sure that it's actually a good thing for them to measure to give us ratings of their pain 5 to 7 days a week, and we'll find out if that is actually the case. And so that's something that they need to actually get credit. So VAMC credit is akin to being able to bill Medicaid, for instance, in the rest of the world. And so that's a real influencer in terms of their behavior. So I mentioned a couple of these other struggles, and I think we're getting close to time here. So I will just stop right there. I was pretty sure that we weren't going to get through all of these other slides. I'll come back once we actually have data and experience for those. So I'll put the study team up here for now and maybe open it up for a couple of questions or feedback. I have a pen and paper right there if anybody has wild ideas on some of these highlighted issues.
Just one comment on the specialist physician, and I put that in quotes. Somebody wrote years ago about you can have specialoids in primary care who aren't specialists. You know, somebody more expert in women's health, somebody more expert in sports medicine, someone more expert in pain, because this at the end of the day is not chemotherapy, okay? It's a handful of medicines and non-pharmacologic treatments, and by discussing cases with nurses, they can become an expert and be the go-to for consultations. You could use existing physician resources in the world, so it could be a primary care physician. You certainly want to use an anesthesiologist who does procedures, but there's other people in pain like palliative care physicians, physiatrists, who don't spend all day doing procedures, and so in some settings, pharmacists, specially trained pharmacists on analgesic optimization. So there are other lower paid specialties that might have an interest in various healthcare systems who could assume this role.
We definitely have talked about pharmacists in our dream for the next study. Right? Locally, it's a little bit hard right now, but I think that's definitely a good one, and a couple of the nurses suggested it as well. Cool.
Thank you. I appreciate Kurt giving the shout out to palliative care docs. And as I was listening to your talk, I realized as a palliative care doc that there's a tremendous overlap and a growing overlap between the chronic pain population and the palliative care population, especially now that we see patients earlier in the disease trajectory. And I have patients whose pain I have managed with a combination of opiates and other approaches for sometimes 2 or 3 years. And so actually there's a need within palliative care for this kind of disease management. And then yes, I think palliative care docs bring the expertise in both opiate management and then other approaches to chronic pain management. And yeah, and I use the word chronic pain because, you know, given how early we see people, it really is chronic. So, thank you.
Thank you. That's great. Cool. Anybody else? All right. Thank you.